Well, hi there, everybody, and welcome to this Royal College of Surgeons of England webinar, the latest in our series, Lessons from Other Countries. And I'm joined by two surgical greats. They're both GI surgeons, and those of you who aren't GI surgeons in the audience, please stick around because they'll have stuff to say which is applicable to all surgeries. I'm going to introduce, first of all, Antonino Spinelli. He's Professor of Surgery at the Humanitas University Hospital in Milano. He's an expert surgeon, great communicator, and even better, he loves the UK. Also, my good friend Steve Wexner has joined us this evening, Regent of the American College of Surgeons, Professor of Surgery, Chair of Digestive Disease Center at the Cleveland Clinic, Florida, and probably the most active surgeon on social media in the world. Gentlemen, thank you very much for joining us. It's great to have you here. And as you know, after you've given short presentations, we'll be having some discussions, and then we will be answering questions from the attendees at the webinar. So first of all, I was going to ask Antonino to begin his presentation. And just to say, on the right-hand side of your screen is Lucy Davis, who's in charge of things in terms of the questions and the presentations. And she'll be helping read out some of the questions as we go along. So this is just to say, this is our standard disclaimer, which says that we have personal points of view and college points of view. Both Steve and Antonino can say whatever they like. Next, please. You'll be aware that the college is putting out continually updated guidance on the management of surgery in COVID world, as it were. I'm not going to read them all out there, therefore you can get them on our website. Next slide, please. We are currently working on a series of documents, if you like, a sort of toolkit for getting into the recovery of surgical services. Again, I won't read them all out, but those are some of the features or the subjects we will be discussing and giving you helpful information on. And now Antonino will make a short presentation, and then we'll talk a little bit about it, and then Steve will talk a bit about that, and then we'll be open to questions from all of you. So Antonino, please.
So thank you very much. Thank you very much, Neil, for the kind introduction and for organizing this webinar. I think that in the next following 7 slides, I will try to go back to those days when it all started and to try to stimulate the discussion on some aspects of the crisis that I think are worth discussing. Next slide, please. We, Neil, we both remember very well those days in which it all started, because it was the last weekend in February. I was skiing on the Mont Blanc, and we exchanged some worried text on a long-awaited visit and long-planned visit to Milano and to La Scala Theatre. And actually, on that day, it started, we were very worried, and it started to a process that led within a few days to a complete lockdown of the city of Milano. All the theaters closed first, theaters, cinemas, restaurants, and schools. And in that same week, after that text that I here made a screenshot of, we also closed our surgical activity apart from oncologic surgery. So restriction after restriction, we stayed for about 2 months, from the beginning of March to the beginning of May. And in May, we started shyly to partially defreezing our lives here in Italy. And what happened in between probably represents one of the hardest pages in the recent history of Italy. Next page, please. So Lombardy is a 10 million region, 10 million inhabitants region, and it's located in the northern part of Italy, as you can see here from this slide. It represents one of Europe's richest region, and its healthcare system was considered at the beginning of the crisis one of the best, not only in Italy, but internationally. So when the outbreak came, everyone thought that if Lombardy collapsed, then every other region in Italy would have sank immediately. Actually, the destiny was this for Lombardy, but was not actually like that for the rest of Italy. You can see in the picture in the upper quadrant here a long line of army trucks that are trying to get many corpses from the out of the city of Bergamo, because there were so many deaths that it was impossible to deal with it within the city. This very dark image is one of the ones that will probably stay long in our memories. Lombardy paid a tribute of about 16,000 deaths up to yesterday to the coronavirus crisis. Even if now, as you can see from the graph, the numbers are decreasing, zooming out and looking, please, on the next slide, at Italy whole, we can see that the 16,000 deaths of Lombardy account for about a half of the whole deaths of Italy. So it was a hugely affected territory. Looking back, we see that Italy was hit first among the Western world countries, and probably, at least a part because of this, Italy was unprepared. And Italy was also not, for Italian, it was also not possible to take into account the data, because the data were extremely few, and the few that we had were probably, looking back, even misleading. And we also have to face a crisis that also was the same that was faced in many other countries later on, and that was the shortage of ICU beds, of ventilators in the most severely affected areas, and also the shortage of PPE that was especially true and especially clear to be seen from the numbers you see in this slide of the positive healthcare professionals, about 28,000, and more than 165 colleagues, doctors, physicians, died of COVID-19 during the last 2 months. Many of them also in our city, and many colleagues we left. So also dramatic was that many core hospital services were put on hold. And please, next slide. And among those, we tend to think that oncologic surgery was partially spared. This is a paper that was published yesterday on the Annals, and this was authored by the whole Department of Surgery from our university, that put together all the data from 54 surgical oncology units all over the territory. So very specialized surgical oncologists, not only colorectal, but HPV, upper GI, sarcoma, and soft tissue tumors. And we saw here that 70% of all of the units experienced a huge reduction of hospital bed for surgical oncology, and that the number of surgeries performed were decreased by about 33% in general, and by about a half in Lombardy. The time from MDT to surgery as a parameter of the process was extremely delayed. By the time doubled within a few weeks. And you can say that even surgical oncology, that is supposed to be one of the preserved areas, actually suffered a lot, and a remarkable reduction in numbers that now need to be caught up with in the next phase. Colorectal surgery, which is what is our specialty, was dealt with about the same number of cases that we performed in the previous years. The graph here shows that the number of cases has been steady, and that elective oncologic procedures were continued all over the crisis. And in 2020, the activity was really close even to the forecasted volumes that we had in a mathematical model of prediction that was based on the 5 year before. What is interesting is that for colorectal surgery, about 1 day of length of stay was diminished within the crisis than in the years before. And this is probably due to the fact that nobody was so eager to stay longer in the hospital, and the compliance of patients was definitely, actually, it was next slide, sorry. I didn't say next slide, please, thank you. And that the number of, here you see the slide on the number and also on the prediction model of cases. Just to remark that patients were much more compliant because of their perception of the risk of staying longer in the hospital. Next slide, please. So the situation today at the end of the first peak of the crisis is actually that our colorectal cancer list is now almost down to 0, 5, 6 cases. It was 57 cancer cases at the beginning of the crisis, while the benign, so-called benign disease or IBD surgery, it's actually suffering from a huge backlog waiting list. So that now the things to do are to take profit of oncology diagnostic gap that was due to the stop of endoscopy procedure and from screening policies that were down for a lot of time. And we have also to rethink and to reprioritize criteria for benign surgery, and this will be an interesting topic for discussion, as well as we can discuss on new models to collaborate with spoke centers, especially for what is possible in terms of expertise to reallocate. Please, next slide. So reopening will be a reopening, probably not to normality, but to a new reality. Because until we don't have immunity, until we don't have a vaccine or an efficacious therapy for this disease, we have to be prepared to persistent risk of COVID, even if we are already in the downslope or in a controlled plateau phase of the curve. And that we also will need to be prepared to secondary COVID waves later on this year or next year, so that we can conclude that COVID-19 is here to stay for some time in our society, and that therefore, being in our society, we also will have it in our hospitals and in our we will need specialized wards and specialized ICU. So we will have to work on how to best adapt our logistics. We will have to work to rethink the priorities of patients, not neglecting anymore the patient that after the first phase in which we all concentrated only on COVID positive patients. Now we have to deal with a coexistence of COVID with the rest of the disease that we are used to. We have to gradually reload, only gradually, our surgical volumes and not all at a sudden. And we also will, especially because we also will deal with a special extreme stress load from our healthcare professionals. So Milano and Italy, and I would say every nation that was heavily affected by this virus are really looking forward to positive signs. And this is how Milano celebrated its reopening after the lockdown. Thank you. Next slide.
And hooray, 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 hooray. So Antonino, just to lighten it a little bit, you, I know, self-isolated away from the hospital because you were worried about getting infection and taking it back to your family. How long were you away from your family?
7 weeks.
Yeah. And those colleagues in the hospital, I mean, there seems a large number of doctors or healthcare professionals who died from the disease. Were they wearing full personal protective equipment, or were there problems with that in the very early days?
Well, the vast majority of the healthcare professionals that died were family doctors that did not have adequate personal protection equipment when they started the crisis, and that was a dramatic moment in which even the recommendation of the World Health Organization, as well as many other organizations, were delayed in recommending what we know now being the adequate equipment for protection of the healthcare professionals. And even screening policies of positive on large scale screening policies were definitely a problem in the very early phase of the disease. this accounts for a huge number of people that definitely were, even if they were aware of the risk, they could not protect themselves.
Yeah. Okay, thank you very much, Antonino. Shall we hear from Steve next, and then we'll start the discussion amongst us all and then open it up. So Steve, please.
Thanks very much, Neil. I appreciate it, and I'm grateful for the opportunity to share a few reflections with the Royal College of Surgeons. It's entitled An American Perspective. It's perhaps somewhat more of a Floridian perspective in terms of local practice, but American in terms of, as you said, I have the privilege of being one of the regents in the American College of Surgeons, and we were, as the Royal Colleges were, very, very engaged on a daily basis with multiple calls every day, video calls, trying to help patients throughout the U.S. By helping to offer principles of safe practice to surgeons and hospitals, and I'll come to that in a moment. So the American perspective is more on a national principles and guidelines level, and the local Floridian perspective is where I am here. So to look first at my clinical practice, if I could have the next slide, please. I'm in Florida, which I think folks pretty much know where Florida is on a U.S. map, but within Florida, the Cleveland Clinic is that lowermost red dot all the way down under the words Fort Lauderdale. That's our main campus in Weston, which is our hub, and I've been working here for going on 33 years since having been recruited by another fellow of the Royal College of Surgeons, David Jagelman, back in 1987. That's where our hospital is. Over the last several years, we have tremendously expanded, and we now we stretch up about a 2 to 2.5 hour drive up the coast, and now include 5 hospitals with 32 outpatient locations, over 1,000 beds. There's about 250 at our main campus here, but overall there's over 1,000 beds now and over 10,000 caregivers. In turn, we are part of the Cleveland Clinic Foundation, which is an enterprise including hospitals in Northeast Ohio, a hospital in Abu Dhabi, Family Health Center in Toronto, Neurology Center in Las Vegas, plus the, of course, Cleveland Clinic London on 33 Grosvenor, which will be coming up, or is up, but will be opening in earlier part of 2021. And I'm proud to say I did get my GMC sorted, now looking at the specialist registration, so I can periodically go over across, being much of an Anglophile, as people who know me would attest. So this is my local environment where I am in South Florida. Next slide, please. Now, what happened in Florida, you can see, is rather a rapid pitch up. Our first cases were in mid-March and just rapidly accelerated. And although we did start to go down, having at least retrospectively hit our peak somewhere in the second week of April, we were initially predicted that our peak was going to be April 17th, was pushed back to April 24th, but then actually in retrospect was probably more around April 6th or 7th that we hit our peak. So you can see we sort of decreased and then increased a little bit and plateaued off. Now, to put in perspective what's happened here, our governor, Ron DeSantis in Florida, issued a directive that all non-urgent surgery should stop. That was done in the earlier part of April. And then on May 4th, you can see this little arrow says May 4th, start phase 1 reopening. That included us being able to resume non-urgent surgery across the state, as well as restaurants and some businesses at 25% capacity. And I suppose we'll talk more about that, because the mere fact that you're opened as a restaurateur or as a surgeon doesn't necessarily mean people are clamoring to come in and avail themselves of your services. Next slide, please. So there's our timeline. We heard about it, same as everybody else. And then as the American College of Surgeons Board of Regents, we convened a group in about March 3rd to 5th timeframe, and we worked with a group called the Surgical Coalition, which is basically 22 surgical societies, including the American Society of Colorectal Surgeons, orthopedists, ophthalmologists, plastic surgeons, vascular surgeons, the like, to come up with a triage guidance for non-emergent surgical procedures. And in part, this document was based on some work that had been done at St. Louis University by Samir Siddiqui, who's a urologist there, on being able to help categorize which patients went into which slot, if you will, for urgent or non-emergent surgery. But then on a local level, this was kind of decided for us, as I said, when Governor DeSantis put a stop to all non-essential medical procedures, including limited office visits. So in addition to us limiting our surgery, we had to limit physical contact, and the physical distancing became very, very important. So telehealth, which in the US had been severely constrained prior to COVID-19, constrained both by payers making people jump through hoops in order to be credentialed to use telehealth, as well as for privacy issues, the number of platforms, the types of platforms being very, very limited. So it was tough for most people to be familiar with the systems, to access patients, and to have some form of remuneration. All of a sudden, there was an explosion in telehealth during this time when people couldn't come to offices. Around the same time, testing started becoming more widely available, so we're able to have a better idea of the levels of prevalence of COVID-19 in a community. Next slide, please. So the American College of Surgeons, as I like to think, is a great convener of groups. So not only is there the Surgical Coalition, which is 22 specialty surgery societies and associations representing all disciplines in surgery. The American College of Surgeons has 85,000 members and fellows. But in addition, under the leadership of our executive director, Dave Hoyt, and our president, Val Rush, being able to work with other non-surgical groups. So the documents which we most recently put together on ramping up surgery as we start to perform non-urgent surgery was a document issued by 4 organizations, the ACS taking the lead, but with the American Hospital Association, the Association of Perioperative Nurses, and the American Society of Anesthesiologists. So these 4 groups jointly crafted the document. And I think this is really the way to get any kind of principles. We hesitate to call them guidelines, but any way to communicate principles, because the buy-in from the people around the table include all parties or most parties who would participate in the operation: the anesthetists, the nurses, the hospital administrators, and other people working in the hospital, and surgeons. I think that's why it may have been so quickly adopted. And I'm proud to say that the American College of Surgeons documents, the first one in particular on ramping down, was immediately picked up by our equivalent of our national payer, the Centers for Medicare and Medicaid Services for patients. They picked up on it very quickly. And even the White House, you know, politics aside, for better or worse, the White House cited it as very good work and good evidence for how we should behave. Next slide, please. So not much after a month, almost exactly a month after we first had our ramp down, we realized it's time to start ramping up. And that document, very similar to what the Royal Colleges have done, was posted online, widely distributed. And again, it was a quadripartite, if you will, document from the organizations that I showed on the last slide. Here in Florida, we started our elective cases, although it really was a bit slower than that. It really was a week later because the governor made his decision on Friday, May 1st, that we could start again on Monday, May 4th. So it was very hard to get organized for surgery that quickly, particularly when we start looking at some of the facets that are necessary to resume non-urgent surgical cases. And perhaps we can discuss, you know, elective surgery is sort of a craw on some people's sides. They say, well, yeah, it doesn't mean it's not necessary surgery. And I rather like the verbiage that I've seen in some of the Royal College documents on planned surgery as maybe a little bit better thing to say than elective surgery. It's not, it may not be scheduled, but it's planned. Next slide, please. So we're in about our third week of planned surgeries being performed. But in order to get there, here are the things that I just briefly alluded to. You can't start doing non-urgent surgery, whatever you're calling it, planned surgery, elective surgery, unless you have a stable or decreasing prevalence of COVID-19 in your local community. And one of the challenges we have here in the US with the size of the country and having areas that are totally remote and rural, and then having areas like New York City. And if I were working in New York City, like one of my fellow regents, Fabrizio Macalassi, I'd have a very different viewpoint of what's going on. But we have a wide and geographically disparate country, so it's important to know what is your local prevalence. And that's what the graph I showed you on one of the earlier slides depicted, that we have been stable to decreasing, not increasing. So then you can start doing your planned cases. But we at Cleveland Clinic, Florida, have a policy that every single patient is COVID-19 tested prior to surgery, within 72 hours of surgery. Asymptomatic patients, doesn't matter. The same applies to any interventional procedure or any patient who's going to be hospitalized. So whether it's cardiac catheterization, colonoscopy, esophagogastroduodenoscopy, or being hospitalized for a non-surgical reason, all patients are tested prior to admission. Before you can ramp up surgery, one of the areas we covered in our ACS principles was to make sure you have adequate workforce. There are a lot of challenges besides people being out sick from COVID-19 or self-quarantining because of having been exposed or presumed exposed to COVID-19, but there are some very real issues. A lot of people who are single parents, for example, and what happens when there's no school for your kids? If school was planned and now your kids are home and you can't necessarily afford or even find help because there's physical distancing, so you don't have somebody coming to take care of your kids. So you have to make sure at a local level that you have an adequate workforce to staff it. Otherwise, you're going to continue to have cross coverage and redeployment of employees to ensure that all of the jobs are being done. Then is there adequate capacity? And Antonino mentioned it. So it's not that COVID's gone away. It's just that it's stabilized or less prevalence. And quite honestly, we never had the kind of surge we'd anticipated. We never saw anything like Milan or Madrid or New York City or London. Much lower level of activity. But nonetheless, there are still patients who have COVID-19 infection in the area. And you have to make sure that should another surge occur, as physical distancing barriers are decreased, that there's adequate capacity in the hospital for intensive care unit beds, for ventilators, for operating rooms, for PPE, for all of these facets of care. And then the last one I alluded to earlier, it's kind of like flipping the light switch, but the lights don't go on straight away, because are the patients really ready to accept that it's a safe environment, even with testing, even if employee testing were present, which in some American institutions it has been. One of my recent From the Front Lines interview for the American College of Surgeons with the chief of surgery at Stanford, Mary Hahn, and they employ routine testing. And Fabrizio Macalassi in New York that I chatted with in an interview that will be upcoming. It's offered, it's not forced, it can't be forced, but offered to everybody. But does that make patients comfortable enough to come back in, even if they've been sitting home on disease? And maybe that's something we could discuss. So next slide. So I'm happy to have had the opportunity to share these things with you and look forward to a lively discussion.
Very good. Thank you very much. Maybe we can start there. Antonino, can I ask you, we've recently been seeing in London, for example, that between 10 and 20% of patients are concerned about the safety of hospital and say, I don't want to come in now, I want to defer until I'm more comfortable that it might be safe. What's the sort of feature in Milano at the moment?
I think that, Neil, you touched one of the most important aspects of the reopening. So regaining the trust of patients to get into the hospital and come with knowing what you have prepared for them. So I think that the critical value is, first of all, in really preparing a completely COVID-free path, which starts from any patients getting into the hospital within a policy of checkpoints, lower the number of entrances of the hospital, put a checkpoint for a couple of questions, temperature check, giving a mask to every person entering the hospital, really questioning whether he or she really needs to get into the hospital or if he is only an accompanying person. And in that case, we adopted a very strict policy for both in and outpatient to not to have any accompanying person, which obviously can be seen as a problem, but it's definitely a measure that in this moment lowers a lot the possible risk. So apart from these, I think that the second important point, after you have established a COVID-free path and a COVID dedicated area in case your hospital is dedicated also to this kind of care, the second is to communicate exactly to the patients what you have prepared and how you have prepared this for them. And this is essential. I think that the American College of Surgeons guidelines for reopening insist a lot on this, and this is also how we what we think is really key to tell why the measures we ask the patient to be, let's say, scrutinized when they get into the hospital are done, and that this is for them, and that with these measures we could avoid any patient in hospital contagion with COVID-19 for elective cancer care, for example. This is already, I think, a huge achievement for an area as ours.
So, Steve, I wonder if I can ask you, do you have a special consenting process? Can you ever say we have a COVID-free pathway?
Well, you can say that the patient will be put in a COVID-free area in that we thankfully have so few COVID patients there sequestered and pooled in an area where they're cared for by a group of people caring only for them, and the rest of the environment includes only patients who've tested negative prior to coming in hospital. So you can tell them they're in an area where none of the patients are COVID positive, and none of the caretakers who are taking care of them are also taking care of COVID positive patients. So from that perspective, yes, but can you guarantee anything? If you listen to some of the serologists and immunologists with whom I've chatted on the From the Frontline series, none of the tests are infallible. Not any of the tests are completely infallible.
Forgive me, do you have a special consent form now? And do you think your patient population understands risk? Do they, can they sort of, if you like, compare the risk of ordinarily going into hospital, which is risky to a degree, with the extra risk of the COVID situation?
Well, number one, we do not have a separate consent for having surgery during a time of COVID. Now, if we were an institution with a high volume of COVID patients, perhaps we might, but that's hypothetical. So no, we do not. Does the patient understand the risk? I think that gets to the standard risk-benefit ratio of why we're operating on the patient. So if it's a patient in whom we've been deferring cancer surgery, or a patient who's been repeatedly admitted for line infections because of TPN, because of an enterocutaneous fistula, or a patient who's got obstructing Crohn's disease, what is the risk of not having surgery compared to the risk of theoretically getting COVID disease? And that becomes part of the standard informed consent, but not a separate consent.
Okay. Right, we're going to ask Lucy to read out the first question, please, and stand by your desks, gents, for the first question.
There's two questions which are quite similar, and it's around undergraduates. So at the college in the UK, the Royal College of Surgeons of England, we have members who are dental members as well. So the question's around undergraduate training for dental students and how's that going in both America and in Italy, and then also what's happening with regards to the training of medical students and their placements in hospitals, and how's that working?
So Antonino first, medical students, and maybe you don't know about dental students, but anyway, medical students and dental students. Antonino.
So in Italy, we have had the problem not only with medical students, which are not allowed to come into the hospital at the moment, but also for residents which were subject to a great decrease of activity in certain branches. They also, I have to say, some of them also made demonstration, not understanding, I think, completely. I have to say that I'm a great advocate of the rights of residents and of their positions, but at this time, I really believe that every doctor, resident or not, is part of a wave that was really difficult to face, at least here. So in this situation, what we try to do is, and what we have done, is to do remote teaching and to also do small group practical simulation during this time. This is all we can do for medical students at this moment. We are not doing any in-presence lectures at this moment. And actually, Italy's government suspended them, the in-presence lectures in the universities, for the next month, at least until the end of the year. So we are completely re-establishing our way of teaching. And we also have students from abroad in our medical university, and some of them went back, but still they all have access to, obviously, to everything that can be vehiculated through a computer and online simulation. Everything else at this moment is partly impaired.
So in the US, it sounds very, very similar. The various medical schools have, back in March, for the most part, had told their students they were no longer to report to hospital for any clinical activity, and that has persisted. So we've not had medical students here since sometime in the earlier part of March. Their education continues strictly through remote means, online, as we're doing today, online educational platforms. Residents were, for the most part, redeployed, since, at least surgical residents, since there were no elective cases going on. If they weren't assigned to the on-call team for accident emergency surgery, they were redeployed to perhaps help in the emergency room or help in the intensive care unit, or perform other functions. So they were helping there. In addition, they were redeployed to help us with telehealth, because, as I said earlier, we started in a big way and rapidly went from, in many institutions in the US, from no telehealth or low single-digit use of telehealth to the majority of visits being through telehealth, through various applications that previously we couldn't use, like Doximity and FaceTime and Google Duo and even Zoom through Epic. There's a lot of different ways to do it. So the residents were continuing to participate in patient care in a remote sense, much as you would for an exam room, that they would, instead of coming in the room first, they'd get the patient on the video first and do the history and review the records, and then conference us in and have a three-way with the patient. The challenge there is some patients are not comfortable with the technology or don't have a device that allows it, and then it becomes standard telephone, but with the resident involved. And I suspect as medical students come back, that's going to be part of it. I think telehealth is here to stay in the US, and I think a lot more remote video-based education is here to stay in the US as well for med students and residents, and even for us. There's going to be more and more remote education.
I'm sure. Okay, Lucy, next question, please.
Does the panel have any reason to believe that the difference in infection and death rates between countries is due to the normal variation in resistance between populations, in addition to the different testing and reporting standards of COVID deaths?
Well, Antonino, what do you reckon?
Well, in Italy, this is particularly striking, I think, because in Italy, you have to think that the problem of COVID that is so overwhelming and that stress us and change completely the life here in Lombardy is almost inexistent in some regions in the center south of Italy. So we have no idea. We would have expected, as said, we would have expected a complete collapse of some regions when the spread of the virus would be greater. One of the theories why that I have heard, but I have to say, I have to admit, I'm not the biggest expert of these. But one of the theories is that through all the wearing of masks and all the, I'm not saying social distancing, but physical distancing that we have been experiencing in this month, probably the charge of the virus has, and the charge of the virus by which a person gets infected could be lower. Whether these can lead to a less symptomatic infection is still to be determined, but it's one of the theories. The other is definitely the climate, but I'm not sure either that this is exactly the point, seeing what happens in Brazil, for example.
Steve, do you think it's all about super spreaders and mega cities, or do you think it's maybe something to do with innate genetics?
Well, I personally think it's less to do with genetics. I think the commonality in the areas that have had super high concentrations have been a lot of people, high density housing, shared public transportation. And if you add that, with the exception of Sao Paulo, in a certain latitude band going along, which I think was between 40 and 60 degrees, if I remember correctly. It's been a while since I've read that article, but which is sort of Wuhan and Milan and New York and Madrid and places that are in that band. Maybe why not in Bangkok? Why not so much in Miami? Las Vegas had a higher penetration, but it's also humidity, not just temperature. And Las Vegas is a dry desert, and here we're much more humid. I mean, I've heard theories, but they're theories. I have no proof.
Okay, Lucy, we don't really know. Let's try the next one.
So a question about PPE. So in the USA and Italy, is full PPE used by surgeons in theatres when operating on patients who have tested COVID negative?
So, Antonino, this is part of the resumption of normal surgical services in inverted commas. So you've got a patient you think is, as far as you can tell, COVID negative. Do you still wear full PPE?
Well, no, our policy is not to wear full PPEs if the patient is tested negative. What we do is actually to try, what we have, let's say, changed and switched from, is that at the very beginning of the crisis, we focused a lot on protecting. Now we try to focus on screening as much as possible, and to really have some measures that can not warrant, but at least can give some more reliability to the negativity status of the patient we operate on. And once we have got that, and we only do this, we do this with 48 hours, within 48 hours testing with real-time PCR swab test, and with even we still use CT thorax. I know that this is debated. We can open that, but we use this for oncologic cases and for major cases. And then we wear, in case of negativity, we wear normal equipment, very standard equipment. And in case we don't get, for emergency, for lack of time, but this is extremely rare, and we don't know the status, then we definitely use full PPE at this moment.
So can I just check, with if the anaesthetist is intubating, you stay out of the room, do they wear PPE? And then when it's all stable and set up, then you kind of come and join in? What's the score about the anesthesiology?
Well, the anesthesiologist doesn't usually begin until he knows about the results of the test, and in case there is no time for that, then definitely he would be using, as much as the whole OR staff, the same level of PPEs that the surgeon would use.
Okay. And Steve, in Florida?
No, much the same, and as far as I know, pretty much throughout the U.S., that patients are tested, generally not the rapid swab test, but tested 2 days earlier, so within 72 hours, and then told to basically quarantine between that time and surgery, so they're not in contact with others. Then come for surgery, and then no, we would not use full PPE in somebody, so they won't even get in the hospital unless we know they're negative. Now, could there be a circumstance where somebody is operated known to be positive? Sure, and in that case, everyone would use full PPE, and as you asked, the only person who would be in the room at the time of induction and intubation would be the consultant anesthetist. There wouldn't be anybody else in the room at that point in time. The interesting question is, how long thereafter are there particles in the air? And I've heard estimates of up to 20 minutes. I don't think we'd wait 20 minutes depending on the stability of the patient. If you could afford it, it might be safer. In addition, if you happen to be in an institution with a negative pressure operating room, you should preferentially do a positive case in that negative pressure operating room.
So the big, sorry, Antonino, carry on.
No, just wanted to say, absolutely in agreement with what Steve is saying. We also would use, we wouldn't see the value of using, while using full PPEs. We know that, for example, from the last 2 months, that all of our anesthesiologists who were staffed in the ICUs of COVID positive patients, basically none of them was positive or was even in contact with the virus, according to our complete screening for antibodies that we have done on their population. So that means that if you are well educated and wear full PPEs, you can be relatively sure that you can avoid to have the contact. So that's in addition to what Steve is saying.
So a similar sort of issue then, aerosol generating procedures. There's been much talk about that in the UK. So laparoscopy, for example, or you're drilling bone or something like that, and the stuff's going all over the place. What's been the view about that? Steve, could you start first of all?
Yeah, I think perhaps there's a couple of good guidelines on there. One that SAGE has worked on with the European Association of Endoscopic Surgeons, and we didn't redo that at the American College of Surgeons. We referenced it, much as in fact we've referenced the UK guidelines that have been put out there. And what they basically say is there's not a prohibition against performing laparoscopy, even in a patient who's known to be positive, but you have to take significant precautions. Obviously, if it's a known positive patient, it's full PPE for everybody. You have to have airtight seal systems. You cannot have random desufflation. You have to use an evacuation device and filters to ensure that all the particulate matter is bled out in a controlled setting and not just blasting pneumoperitoneum around the room. So you have to have smoke evacuators, filters, and airtight systems if you're going to do laparoscopy. But, you know, to play devil's advocate, laparoscopy may be better because in any patient, obviously, there's going to be less postoperative morbidity and less pain. And when you're talking about, as we know from our Neil Bangus study, the COVID-19 surge study, the major cause of mortality is pulmonary. And if we can avoid pulmonary complications by avoiding a big laparotomy and splinting in these patients, it may be beneficial. We just have to be careful when we do it.
Yeah. And Antonino, would that be a similar answer?
Yeah, I would echo exactly what Steve is saying, adding just one consideration that maybe the only positive thing about this discussion about smoke and laparoscopy and everything else is that it made us even more, actually a little bit more aware as surgeons of surgical smoke, which was a completely neglected topic, even if abandoned topic, I would say, not neglected, but abandoned topic for a while. And it regained popularity with this risk, which still has to be demonstrated. Still, as far as today, as much as I know, it's not demonstrated that any vital virus, that any direct virus transmission is proven to be happened through aerosolization. But still, definitely in not knowing, it's better to be on the safe side.
Yeah, and you're absolutely right. There's lots of research going to go on about both of these topics in the next little while. So Lucy, next question, please.
So how are you managing kind of fear amongst healthcare teams and people worrying about kind of going into work? And then also, do you think it's had an impact on surgical training?
So Antonino, if you could answer that first. Fear of going into work. I'm sure you had a little bit of that to start with.
Sure. I think that this is a very, very important topic. So I have to say that within our team, we had to, at a certain moment, we were asked to deploy some of our members to COVID wards. And it was interesting to see how different people would react differently to this request or to this need. What we have seen is that 2 people out of 4 voluntarily proposed themselves immediately without even knowing how long and how were the conditions, while the rest really were extremely afraid. And when we had to change after 2 weeks, we decided we wanted to change to give a turnover to the ones that volunteered first. It was difficult to do that for the others, so that the first 2 that volunteers, they stayed also for the rest of the time. So I think this is a bank of proof of some different qualities. It's not that that being fearless is definitely better than to be rightly afraid of an unknown situation and a risky situation. But every time there is a difficulty, it's interesting to see how a human being differently react. Apart practically, we did not experience a lack of volunteering, so I can't say that I have to force anybody to do that.
Great. And Steve, have you had any fear amongst medical staff?
I think it was more the fear of the unknown at first. So in early March, when we thought, we heard from Antonino and we heard from Julio Mayol and others about what was going on, and then very quickly from Fabrizio in New York, there was fear. You know, are we going to be overwhelmed? Are we going to not be able to even care for all the patients? Are we going to have to make life and death decisions about who gets a ventilator and who doesn't? And, you know, can we be putting beds in our conference centers, and all these ideas for surge planning? I think that was it was the tremendous fear of the unknown. Like, we don't know where the end is. We don't know how bad it's going to get. And therefore, will we fail at being able to take care of people as we should? Once we started to slowly realize we were not, thankfully, going to see that same magnitude wave, then that fear went away. And in addition, we always had adequate PPE. From Cleveland Clinic was wonderful from early on. Our local CEO, Will Barsoom, our enterprise CEO, Tommy Mihalovic, through all of the people reporting to them, twice a day we were meeting, getting reports on what was happening, including the amount of PPE available, which was always adequate. It was never an issue. So people felt that if they did have to go and meet this demand, they'd be able to do so safely for themselves. Now the issue of fear has gone away, as far as I know. Now it's more of a mystery as to, you know, what do we do next? Because again, patients aren't necessarily flocking in, and we think we're making a safe environment, and that's nationally. That's, as you said, 10 or 20% of patients aren't comfortable. In some places, that number is higher. So, yeah, fear of the unknown.
Fear of the unknown, indeed. Lucy, next question, please.
And sorry, and the second part of that question was around training, and whether training's been impacted. I know we mentioned it briefly before.
Sure. Absolutely.
Sorry, I neglected that part. Yeah, definitely a big impact on training. One of my recent interviews was with Joe Beiske, who's the executive director of the American Board of Surgery, and the American Board of Surgery recognized that and has given dispensation for case numbers, because they recognize people will not have achieved the standard case numbers because of this hiatus of, thus far, depending where you live, at least 3 months of not getting case material. So training is impacted, and people are thinking of creative ways around that. Now, there is also value in learning other skills, and people were honing their skills in ventilators, and people were doing intensive care unit care. So it was different education, and that's why I think the decision, and I'm not on the American Board of Surgery at this time, but that's why I think the decision was to just modify numbers rather than to say, well, you're not going to have the skill set to become certified by the board.
So if I came to Florida to do a fellowship, would I get any cases to do right now, or are we still talking about it being pretty difficult for people wanting to specialize in a branch of surgery?
No, we're ramping up. It's not as rapid as we had envisioned, but we are definitely, and again, nationally, not just locally, because I speak with the other regions pretty much daily, and it's we're getting there. But I should hazard a guess it's going to take a solid 4 to 8 weeks at any institution before people are really at full tilt again.
But you think the volume? Apologize. Do you think the volumes will return to normal? And do you think if they don't, then fellowships might have to be longer, for example?
Yeah, but I think volumes are going to return to normal because there's no evidence that COVID-19 somehow confers immunity on cancer or colitis or other things. So those patients still presumably have disease with the same prevalence and the same levels of acuity and severity. So if anything, what we're anticipating, we thought it would have come sooner, is a surge in the post-COVID-19 surge, when people who were home with their diverticulitis and home with their colitis and getting a few extra rounds of chemotherapy prior to surgery, when they all came. They haven't come yet. Anecdotally, I can tell you people are now starting to say, okay, latter part of June, I'm happy to come in, or early July. So if that's what happens, I think there's going to be a rebound phenomenon. And a lot of institutions are talking about evening hours in theater and weekend hours in theater.
Yeah, same here. So Antonino, the training issue for the residents?
So we had that. We definitely had that. That was more important probably for the first year's residents than for the last year's ones, because the first years are more concentrated on more elective and smaller procedures, and they have to be completely practically without those procedures for a long time. And they were asked to be whether they wanted to be deployed either to emergency room or to COVID wards. I think that among the potential learning additional skills that they have learned, among them probably we have to mention also some soft skills in terms of collaboration. They have given great proof, really great proof of their willingness to collaborate, and they have been redeployed in any possible use, from the checkpoint at the entrance of the hospital to the intensive care of COVID patients. So I think that it's an experience for them. They have been through an extraordinary time for a doctor, and independently from their specialty, I think that being active part of this time is better than having a couple of more cases that they can recover later on. I hope.
Stories to tell, absolutely. Lucy, one last question, please.
Of course. So a question about physical distancing and contact precautions. Why is this not respected in hospitals? It might be a UK thing.
So the suggestion is that in the coffee room after the case, everybody's still just like they used to be, up close and friendly. Antonino, what's the score in Milano?
No, very clearly, no, that's not happening here. We, at least in our hospital, we don't have, almost none have coffee rooms, and which is obviously it's an unfortunate event, but I know how you're used to have. Unfortunately, we don't have those rooms, so it's not happening. But in general, I have to say that even meetings only happen in a very distant auditorium, and maybe if there is something like that, if there is a break of this rule, it is for within the same small team. For example, after operating, talking to near, something like that, that can happen, but every time with a mask. So now you see me without a mask in the hospital only because the door is shut down.
Interesting. Steve, social distancing?
Well, I think our physical distancing is much more akin to Antonino's than it is to the UK. I can tell you that in the operating room here, the tables and chairs have been removed, so in the lounge area. So if you want to go, you can stand, but clearly, A, people aren't going to stand around too long, and B, probably not right next to each other. So when I do observe, purely anecdotal, there is appropriate physical distancing, plus use of masks, there's hand sanitizer everywhere you look, and soap and water, obviously. In terms of the cafeteria, a lot of the tables and chairs have been removed.
Yeah, we don't have.
Right, same. There's very few tables and chairs spaced out. When you have places like a line to get in the building to have your temperature checked, there's 2 meters apart circles where you're supposed to stand. People are obeying those. People are not clustering together. People are respecting it. And in the waiting areas, no patients are allowed to bring relatives or friends or anybody. They come to the visit by themselves. And then again, in the waiting room, like 2/3 of the chairs were removed. So there's far less places to sit. And everybody's wearing masks. So I would say there's excellent adherence to physical distancing and masks and hand washing here.
Okay, great. Those are all super observations. We've had some great questions. We've had some really good discussion. I'd like to end by thanking Antonino and Steve very much indeed for joining us, for some excellent contributions, very, very interesting, very stimulating. And then amongst our staff to Lucy and Jane and Misha for their help setting this all up. For those who didn't get your questions answered, we will still be having a look at those in the next day or two, and maybe getting to grips with them and giving some answers. And I hope you'll come along to the next webinar. You can see there, human factors, the 5-minute brief and why it matters with Professor Peter Brennan. Do join us then, and thank you for joining us this evening, and goodbye for now.